Yes, it is visible.
Okay, so good afternoon, everyone. Thank you, AIOC and Nepal Ophthalmic Society for giving me this opportunity. So I'll be talking on a topic, Descemet membrane detachment. Myself, Dr. Prafullla, I am an Associate Professor at RP Center, AIMS, New Delhi. So this picture, this is just a picture of one of the patient referred to me. The patient had undergone cataract surgery 3 days before, and as per slit lamp examination, everything was fine except corneal edema. So I'll come to the video of this patient in my subsequent video. But remember, all such patients may be harboring some sort of DMD. Few words about the anatomy of Descemet membrane. We all know this is the innermost layer with thickness of around 8 to 15 micron, and it has two parts, mainly anterior banded and posterior non-banded layer. Most important part to remember is, remember, the Descemet membrane is attached to stroma with an interfacial matrix, as I have highlighted in this arrow here, orange arrow. So this interfacial matrix, it consists of irregularly arranged collagen fibers along with some glycosaminoglycans. Why I am saying this point here is, if you leave a Descemet membrane detached for a long time, these glycosaminoglycan and hyaluronate, all that is important for adhesion, they are gradually degraded. So the adhesibility of the DM decreases as you delay the intervention of DM redetachment. Causes, we all know cataract is the most common cause, and there are other causes like PK, DALK, glaucoma surgery, and chemical injury. All this can cause, but most commonly it's seen in cataract, especially ECC cases where the incidence is almost up to 5%. With FECO, it ranges between 0.5 to 1%. Spontaneous DMD can occur, especially in cases of corneal endothelial dystrophies and as well as corneal ectasia. So risk factor, I'll not go through all the risk factor, but remember, old age, endothelial dystrophy, hard cataract, and poor surgeon skill. These are the primary causes for DMD. During surgery intraoperatively, when you are using blunt instrument or the eye is little bit hypotenuse, you have given a peribulbar block, and the pinky or the massage was given for a long time, and there is hypotony, and when you are entering with your instruments or knives, if the globe doesn't offer that much resistance, then it's likely that you may land up in DMD. Post-operative, as I said, few cases there can be spontaneous DMD, most commonly FECD and keratoconus. Natural course, remember, in all the surgeries, for example, in cataract, almost one third of our patients, they have some sort of DMD, which may be localized to your MBR port or main port, but these are not visually significant. Self-resolution is usually the rule. However, in 5 to 10% of cases, this can be extensive, and all these cases, they need intervention. This is a paper which I published when I was doing a senior residence at RP Center. Here, the initiating point of this research was that most of our residents, when they are operating and they are writing on slit lamp examination, everything is fine. And when we did ASOCD, we could find some sort of DMD underneath the edematous cornea. So that was the point where we realized all such non-resolving corneal edema cases should undergo ASOCD. And this is the classification, is basically a modification of macule classification to guide you how to plan. So basically, we classified DMD into superior inferior half or diffuse involvement of cornea. If superior inferior, then it can be further categorized as planar and non-planar, scrolled and non-scrolled. So I'll just show you a few pictures. Here you can see the DM is detached, but the distance is less than 1 mm. So we label this as planar. Anything more than 1 mm, as you can see, it's more than 1.1 mm from the stroma, it's a non-planar one. When the edges are rolled, it's known as a scroll DMD. If not rolled, then that's a non-scroll DMD. So based on that, we recommended this management guideline. Remember one thing, when the DMD is in superior half over cornea and it is planar edges, then you can simply get away with air injection. In all rest of the type of DMD, it's better to go for some sort of gas injection like SF6 or C3F8. So I'll just run through few video. This is one technique of attaching a DMD. As you can see, there is a diffuse DMD extending from the main port to the periphery. Here, the technique is simply you go in with a 30 gauge needle with C3F8 air, anything, then just keep on pushing the air to achieve a watertight chamber, airtight chamber. When the pressure is high, keep the eye for 8 to 10 minutes, and then you can remove few of the air. You can do some massage with a cotton swab or a Merocil spear. so that will help you in DM reattachment. This is a technique that I prefer. And in this, you can say you can say it's a bimanual technique, because when you are injecting air and the patient is glaucoma or having some risk factors for optic nerve damage, you can damage the optic nerve. So here what I do, this is the same case which I said you that somebody referred me, suggesting that on slit line everything was fine, but you can see when I was using the microscope into density, there was diffuse DMD, but it was the cornea is too much edematous, so the surgeon might have missed that. So when you are dealing with such cases, what I do is I make two entries. One entry to balance my interchamber pressure, the other entry is to increase the intraocular pressure. You can see this is a 30 gauge needle. I'm going in, and preferably the site of entry is limbus or area where the DM is not detached. And this is another needle. So one of my needle is not having any syringe. It's an open hub that will regulate my IOP. The other needle is having a tuberculin syringe with C3F8 or SF6 or air, whatever I prefer. So when I'm injecting air into the or gas into the interchamber, the other needle helps me to titrate my intraocular pressure, as you can see here. And after keeping the air gas for 8 to 10 minutes, you can burp it. And if your patient is having a PI, you can leave as much as you want. But if there is no PI and you haven't done a PI, it's better to leave the size of exactly how much the pupil is dilating, or two-thirds of the anterior chamber. And this massage, as I shared you, that usually helps you in taking care of the small permanent fold that might have formed. So this is another video. This is a case of fuchs endothelial dystrophy with advanced cataract. So I was planning two-stage procedure. This was the first case. Phaco, I have already done the phaco. You can see the cornea, edematous, gutte, and folds there, and because of fuchs endothelial dystrophy. But however, if you notice carefully in the main port here, there was some focal DMD. So such cases you can leave it like that, because ultimately you need a keratoplasty. Or the other technique is fill the interchamber with air and burp the air through the main port or the port where the DM is detached. By doing so again and again, the folded DM will become unfolded, and then you can leave two-third air or C3F8 to avoid post-op detachment. This is a simple trick. At times, if the main wound is having a detachment which is extending too much, you can suture this side and do all this maneuver from other side. So remember, whatever the procedure that you prefer, explain the procedure to the patient, take consent if it is mandatory in your part of the country, and it's better to pilocarpinize to minimize the damage to lens or intraocular lenses. Anesthesia, you decide depending on the patient's pain tolerability. 29 or 30 gauge needle nowadays, people prefer that. Go through an area which is either free of DM detachment or limbal area. Complete air fill should be achieved, and wait there for 10 to 20 minutes. And after 8 to 10 to 20 minutes, you can see if the chances of redetachment is still there, then you can wait for more than that, or you can simply burp the air. In the end, I would advise you to dilate the pupil to avoid the complication of post-op pupillary block glaucoma. I'm a corneal surgeon, so I do encounter such cases also. This was a case of PKP with detachment. As you can see here, the technique is same as you do for post-cataract surgery DMD. However, here the case are a little bit difficult because of the tricky graft-host junction. However, ultimately such cases also they get reattached. This is the last video I will show you. This was a case of DALK. Here it was a double trouble for me, because the DM was detached and the fluid was there between the Duas layer and stroma, as well as between the Duas layer and the DM membrane. So here I had to do initial technique is simply cut few suture and do some massage and inject the air, fill the interchamber complete with air. So the fluid that is there between the stroma and Duas layer will come out. But when the fluid is there between your DM and Duas layer, you have to give a short or a simple nick with a 30 gauge needle. As you can see here, the moment you do that, the Descemet membranes gets reattached. So this was the post-op picture of that patient. Sorry, I missed that. So these are other techniques that have been described by surgeons, like supradescemet air detachment, air drainage, or fluid drainage, and some people have even described DMEC or post-op DMDs. However, I haven't encountered such cases till now. With simple management like bimanual air bubble or gas injection, most of cases heals nicely. So with this, I'd like to conclude my talk. One last point: when you are dealing with a difficult patient, remember while injecting C3F8, please counsel them that this gas is going to stay for 4 weeks, or else for next 4 weeks they will be after your life ki vision to nahi aaya. So with this, I would like to conclude here. Thank you for a patient hearing.
Thank you, Dr. Prafullla. It's a wonderful video session and all the tips which you gave, especially the burping part. Very nice. Even for anterior segment surgeons, it'll be good during cataract surgery. They can just put the air and a little burp, it'll unscroll.